Hello everyone, I'm Dr. Nisha Ganga, Senior Resident in the Department of Respiratory Medicine at Chettinad Hospital and Research Institute. So in this module, I'm going to discuss about the continuous positive airway pressure. So the overview of my topic is history, mechanism of CPAP, CPAP indications, contraindications, benefits, interfaces, side effects of interfaces, CPAP titration, challenges, summary. The history of CPAP is thanks to Dr. Colin Sullivan, an Australian physician and professor who invented a machine in 1980 applying continuous positive airway pressure for use on adult patient with sleep apnea at Royal Prince Alfred Hospital in Sydney. So these are the evolutions of CPAP machine which was invented from 1980s till today. So the types of PAP devices are CPAP, which is a manual PAP. It's a continuous positive airway pressure. BPAP is a bilevel positive airway pressure. APAP, auto-adjusting positive airway pressure, and ASV is adaptive servo ventilation. What is CPAP? It's a non-invasive ventilation. It is a continuous positive airway pressure which is applied to the airways of spontaneously breathing patients throughout the respiratory cycle. Now you can see the graph over here where it is a continuous positive pressure. It provides a constant pressure which acts as a pneumatic splint that prevents the airway collapse during sleep. So CPAP is a mainstay therapy for treating obstructive sleep apnea. So now we are going to discuss about the mechanism of CPAP in OSA. CPAP delivers the continuous positive airway pressure to keep the airway open during sleep. It acts as an pneumatic splint to prevent the upper airway collapse. It increases the lung volume, that is the functional residual capacity, and it improves the oxygenation, reduces the apneic episodes, and improves the sleep quality. It prevents nocturnal hypoxemia and cardiovascular stress. So the indications for using CPAP in obstructive sleep apnea patients are moderate to severe obstructive sleep apnea, mild OSA with the symptoms and comorbidities, overlap syndrome which consists of a chronic obstructive pulmonary disease along with obstructive sleep apnea, and obesity hyperventilation syndrome. So in overlap syndrome and obesity hyperventilation syndrome, BiPAP may be used if CPAP fails. The contraindications are untreated pneumothorax, severe bullous lung disease, severe hypotension, arrhythmias, facial trauma, and facial surgery. What are the benefits of using CPAP on OSA? So it decreases the number of apnea episodes, reduces daytime sleepiness, decrease blood pressures, decrease the risk of RTA, decrease snoring, improves the nocturnal oxygenation, improves the neurocognitive performance, and improves the quality of life. So now we are going to discuss about the types of interfaces. The first one is the nasal mask. The nasal mask, it covers the nose, comfortable and lightweight, and consideration is the mouth breathing can cause air leaks or dry mouth which may need a chin strap. It is suitable for a patient who breathes primarily through the nose. So this is the nasal mask. So it covers the nose. So the next comes the nasal pillow or the nasal prongs, where it is a small cushion or prongs rest just inside the nostril. The advantage of using this nasal pillow is minimal facial contact, it's less claustrophobic and may cause nasal irritation at higher pressure. So it is not ideal to use for high pressure settings. Good for patients with facial hair or those who feel hot with a full mask. So this is oronasal, that is, it is a full face mask. So it covers both nose and the mouth. It is ideal for mouth breathers or patients with nasal obstruction. It is bulkier, higher risk of leak around the bridge of the nose. Maintains pressure even if the mouth opens during the sleep. So this is a hybrid mask. It's a nasal oral hybrid mask. so which seals around the mouth while using the nasal pillow. The advantage of using this mask is it has a less surface area than the full face mask and may take time to adjust, not as widely available as nasal or full face mask. It is useful for patients needing mouth coverage but desiring a lighter fit. The total face mask, it encloses the entire face covering eyes, nose and mouth. The advantage of using this mask is reduces the pressure source on the nose and requires a careful fitting to avoid leaks and eye irritations. It is helpful when patients cannot tolerate other masks or have facial abnormalities. So next comes the helmet interface, which is less common in OSA but it is used in critical care. So it is a transparent hood. It covers the entire head. The advantage of using this is it provides full face protection and it reduces the aerosol dispersion. It is bulky, requires specialized setup and not typically used in routine for OSA management. But it is useful in acute respiratory failure or during pandemics. So there are side effects for using PAP treatment and we intervene also. So the common side effects are nasal symptoms such as congestion and obstruction. So where we try to use nasal steroid inhaler, antihistamines, nasal saline, humidifications, full face, nighttime topical decongestant, and if there is an epistaxis, nasal saline, if there is a pain, humidification, and if patient complains of rhinorrhea, we then will go for nasal ipratropium bromide. The other problems such as if patient complains of pressure intolerance, then we will intervene on ramp, flexible PAP, BPAP, APAP, lower prescription pressure temporarily which accept the higher AHI and lower pressure along with adjunctive measures such as elevated head of the bed, side sleeping position and weight loss. If there is an aerophagia or bloating, then we will change to BPAP, flexible PAP or reduce the pressure. So the side effects of using mask, if there is an air leak, then we will intervene in proper mask fitting. If there is a conjunctivitis, proper mask application, and if the patient complains of discomfort or noise, then we will use a different brand or type of mask. If patient complains of skin breakdown, avoid over tightening, intervene as above for leaks, alternate between different mask types or use nasal prongs or pillows. Tape barrier for skin protection. If there is an claustrophobia, then change over to nasal pillow or prongs interface or desensitization for the patient. If there is a mouth leaks or mouth dryness, then treat nasal congestion if present, chin strap, heated humidity, full face mask or consider BPAP, flexible PAP or lower the pressure or use APAP. If there is an unintentional mask removal, low pressure alarm or consider increase in pressure. So according to the guidelines, we titre the CPAP. So it is based on the guidelines that adults and children more than 12 years or children less than 12 years. So there is a minimal pressure and the maximum pressure. So the minimum pressure in case of both adult and children of both more than 12 years and children of less than 12 years, the minimum pressure used is 4 centimeter water, but the maximum pressure for adults and children more than 12 years is 20 and for children less than 12 years is 15. And we have to titre the CPAP by increasing CPAP in every 5 minutes. For case of adult and children of more than 12 years, it's based on the increased pressure for greater than or equal to 2 obstructive apneas or greater than equal to 3 hypopneas or greater than equal to 5 raras or greater than equal to 3 minimum loud snoring. But in case of children less than 12 years, the increase in pressure for more than or equal to 1 obstructive apnea, hypopnea and minimum loud snoring and greater than and equal to 3 raras. We will switch to BPAP when patient is not tolerating to CPAP or even still present on CPAP of 15 centimeter water. So the challenges of CPAP titration is manual titration is necessary to identify the optimal pressure. It requires a level 1 sleep laboratory which adds to overall cost. Operation demands skilled and trained technicians. Such titration facilities are not uniformly available across all cities and towns. Patient comfort tends to decrease as pressure requirement rise and less effective in patient with positional OSA or REM related OSA phenotypes. So we have to follow the patients, those who are on CPAP. So we have to advise the patient to come after a week or 4 to 6 weeks, 12 weeks, 6 months and after 1 year. The summary of this module is the CPAP is a mainstay therapy for obstructive sleep apnea and it is a non-invasive ventilation. It is a continuous positive airway pressure that is applied to the airways of spontaneously breathing patient throughout the respiratory cycle, acts as a pneumatic splint that to prevent the upper airway collapse. Thank you.